Hi, hello, good afternoon, everyone. My name is Dr. Julio Meza, and thank you for inviting me to present here to the Armenian American Medical Society. It's a big honor for me to be back and to speak of a topic that is really important to me based on the things that I practice in a daily basis. Before I go into the topic, in the first slide, we have the planning committee for this great conference that we have had the opportunity to enjoy together. We have their financial disclosures and other information that you may need to know beforehand. Here is a little bit of my background. Okay, as some of you may know, I'm originally from El Salvador, and I did all my training in my basics of medicine in El Salvador, and then I moved here to the United States, and I had the opportunity to join UCLA in their International Medical Graduate Program. Uh, Completed that successfully, posterior to which I was allowed to stay, and actually I was chosen to be part of the residency program at UCLA in family medicine as well. And as I completed, I had the opportunity also to join the Addiction Medicine Fellowship, and now I perform as one of the addiction physicians at UCLA. One of the things in which I'm quite involved nowadays, especially for the past 2 years at this point, which is quite amazing how quickly time flies, is regarding the involvement that we have in the substance use department with our colleagues in hepatology. So at UCLA, I have the opportunity to perform the inpatient evaluation for patients who are undergoing uh, candidacy for solid organs, specifically liver. And as well, I'm in charge of the post-transplant clinic for anyone who has had a liver transplant in which alcohol consumption has been involved. So definitely the topic chosen to be discussed today is specifically the diagnosis and treatment of alcohol-associated liver diseases. All of us, we know about opioids and how much they have actually affected our society and all the different problems that they brought ever since the early 2000s. A good thing, and we had really good news this year in which pretty much we had a big decrease on the number of total overdose deaths due to opioids in the United States of America. So that's definitely a mark that we're making a dent on such human tragedy that we have lived ever since the early 2000s. But something on some occasions takes a background, and sadly, that one has plateaued for quite a big period of time, is how much alcohol does affect our patient population. And despite we knowing how many organs can be affected by alcohol, some occasions we kind of place our efforts in other areas, which has allowed pretty much the fatalities and actually complications and morbid conditions due to alcohol to continue to cause a lot of problems and definitely cost a lot of lives in our country and definitely affecting our families and needless to say the economic cost that this can bring. I do not have any financial disclosures to share. I have nothing, no relationship with any non-allowed company. And here we have some of the really interesting statistics. And today I'm going to concentrate only and only on alcohol-associated liver disease, which is really interesting because if you see the most recent report by the Surgeon General of the United States, which is really comprehensive, it speaks volumes regarding not just alcohol-related liver disease, but also association in between alcohol and malignancy overall, okay, from cancer of the esophagus all the way to even breast cancer, okay, in which even the incidence of breast cancer can actually increase due to alcohol consumption. Definitely is something that is a really good read to have, okay, so we can have a better idea on how alcohol affects every single organ in our body. Speaking of alcohol-associated liver diseases specifically, we have some statistics compiled from the year 2000 all the way to 2021, in which we can see on three different graphics, one, the diagnosis of alcohol use disorders on two genders, okay? As well, we have alcohol-associated liver disease, and then the development of liver cancer primarily due to alcohol. Something that, as we can see, based on the numbers themselves, right, is that for both genders, female and male, alcohol usage has doubled over the past 20 years. Now, granted, we're not counting the statistics of the COVID-19 pandemic, which definitely it caused a lot of trouble when it comes to alcohol consumption itself. So we have more individuals definitely consuming more alcohol, hence more people being diagnosed with alcohol use disorder. When it comes to alcohol associated liver disease, whether we call this alcohol associated hepatitis or alcohol associated cirrhosis, we see as well that the numbers have doubled in the same way as it happened with alcohol consumption. So definitely there is a direct correlation, almost one to one on both aspects. And similar scenario is seen as well when it comes to alcohol-related primary malignancy, specifically HCC. So we're speaking of individuals who might have developed an alcohol use disorder at some point as well. They have some type of alcohol-associated liver disease, let's call this one cirrhosis, and upon progression and definitely not adequate monitoring and maybe not decreasing alcohol intake, right? We have that. There is also increase on the on liver cancer overall in these patients in which alcohol consumption has increased. Uh, so pretty much in the United States of America, right? Most of we have two main conditions that lead usually to cirrhosis and also that lead to potential transplant in the United States, and those are hepatitis C, viremia, and viruses, and then alcohol consumption. The good thing regarding hepatitis C virus infection is that we have really, really good medications nowadays to treat it. For alcohol use disorder, we have good medications that can help us to achieve sobriety as well, but definitely the utilization is quite minimal. In case of HCV specifically or hepatitis C virus, we know that there is more uptake regarding the use of those medications. And added to that, the treatment for hepatitis C virus infection is going to imply 8 to 12 weeks of treatment compared to alcohol use disorder, in which for the most part we're speaking of a lifetime of change that will be implied, in which non medications occasionally are not the only solution that we may have. So definitely something to take into account that today, even with the best research that we haven't been able to achieve definitely decrease in major capacity the numbers of people who are affected by complications due to alcohol in their liver. Now, how do we diagnose alcohol use disorder? In our case, as addiction medicine physicians, we use the DSM-5 criteria to do such task. And pretty much the DSM-5 criteria is going to be all that set of questions that you see right there that we tend to ask our patients when they visit us for whether it's the first time or for follow-up. And depending on how many of these questions we get answered yes to, then a diagnosis will occur. So we can have three stages when it comes to the diagnosis of alcohol use disorder. We can have patients with what we call mild alcohol use disorder, are going to be those patients in which we have two or three of these characteristics being present. On those in which we have 4 to 5 symptoms present, definitely we're going to have moderate alcohol use disorder, and definitely severe alcohol use disorder is going to be that individual that meets 6 or more of these criteria. So that's how we pretty much categorize the severity of the condition. And also it can help us with guidance to treatment. Some occasions for patients with mild alcohol use disorder, unless time might be a potential constraint, medications may not be needed. Therapy alone might suffice, okay? To some people, even rarely, but it does occur, even just going to self-help groups, also known as mutual help groups, might be helpful enough, okay? Moderate alcohol use disorder, we have more the intervention of medications that can help us to decrease cravings for alcohol. And severe alcohol use disorder definitely is more comprehensive. So ideally, it's a combination of both medications and as well therapy to treat these patients. Now, what I showed you before were the diagnostic criteria, but most of the important work, even before doing the diagnosis, right, is just to have that conversation with someone that we might feel concerned regarding to their intake of alcohol, how the alcohol consumption being present might be affecting their livelihood as it is. So definitely screening is one of the key factors in this topic. You will be amazed how many occasions I'm on service performing a liver transplant evaluation in which upon talking to a patient, they mentioned to me, look, Dr. Mesa, I was told that I have fatty liver 7 years ago. And as in my case, asking as a patient, what do I need to do in order for my fatty liver to improve? They told me that definitely had to do some diet, maybe some exercise. I know that there is no medications to improve fatty liver, but I was never told that alcohol was also a cause of fatty liver. And that's a common conversation that I tend to have. And it's important to remember that pretty much any fatty liver infiltration is going to be equal to inflammation of the liver for any given cause, whether we call this one viral, whether we call this one toxic, or whether we call this one autoimmune. So excessive alcohol consumption will lead to fatty infiltration of the liver. How to distinguish if is alcohol the main cause of such change is going to be one, performing adequate testing for other causes. And another thing, simply asking, okay, how much alcohol are you consuming? So the National Institute of Alcohol Abuse and Alcoholism, they recommend for the most part to screen with the single question, which is to ask to a patient how many times in the past year have you had 5 drinks or more in case of a man, okay, in one day, and for a woman, how many times in the past year have you had 4 or more drinks in one day? So if we have definitely one single episode in the past 12 months, definitely it meets criteria that this patient might have some type of nociceptive way to use alcohol. And then we can proceed with more comprehensive, whether it's screening or if deemed appropriate, especially we have some other changes, maybe it's happening more than once and it's affecting their lifestyle, it's affecting their work, it's affecting their marriage. Maybe we see signs of liver inflammation that cannot be otherwise explained by other biomarkers or any other condition. So maybe a referral might be necessary. So these patients can be treated accordingly. Some other mechanisms to as well screen, as we know, there is the famous cage as well. It's another screening mechanism. Another one is the audit and audit C. The audit is quite comprehensive of a screening questionnaire, so a lot of people tend to defer that and they prefer the audit C, which is a 3 questions being asked to a patient. And if there is identification of harmful usage of alcohol, then it proceeds to do a full audit. Uh, so we can have an idea on the usage of alcohol by an individual. So that in this way, right, by us detecting that definitely there is harmful pattern of usage of alcohol, we're going to be able to know if this patient needs to be referred to treatment, if this patient is someone that should be started to be treated today, and in that way we can engage this patient in active fashion on treatment of their alcohol consumption that might be quite affecting their livelihood. Now, as you notice, 2 slides ago I mentioned how to diagnose a patient with alcohol use disorder. And if you notice on the 11 questions, there is not even one that mentions any labs. And why is that? We do not diagnose in my specialty of addiction medicine someone with an alcohol use disorder based on lab tests. Now, they can be extremely, extremely helpful, especially in the primary care realm, cardiology, hepatology, any other area in which we want to engage this patient more actively on their treatment. For example, we have some indirect biomarkers of alcohol usage, and those are going to be the ones that we have on the top left-hand side, okay, the traditional markers. One of them is going to be liver enzymes, specifically AST and ALT. We have, if we recall, the classic saying that when alcohol is causing liver inflammation and actually the liver being affected due to alcohol, elevation of AST will be double the one from ALT. That's quite correct. It's not necessarily 100% specific, but it has a fair specificity. It's not too sensitive though, because even on patients with cirrhosis, when compensated, they will not have elevation of their AST, ALT, but it's really, really useful. Another indirect marker is going to be bilirubin elevation specifically. GGT, more than alkaline phosphatase, is going to tell us that likely there is excessive alcohol consumption on that patient in which there is no ductal type of conditions or no conditions that might be affecting the common biliary duct or any other portion of the biliary tree. Evidence of macrocytic anemia as well, right? In absence of vitamin B12 deficiency or folate deficiency. The good thing when we start to see these markers, right, it gives the idea to a patient that definitely alcohol is having more of an effect in a systemic fashion. Just today, to give an example, another that not necessarily is a marker, but is a constellation of findings that we can see on individuals' blood work, right? It's going to be definitely signs that bone marrow is being affected by alcohol consumption, which it can lead to actually pancytopenia. So today I actually had the opportunity to see someone who deemed that he wasn't drinking much, didn't allow me to actually perform one of the specific tests for alcohol usage, which I'm going to discuss shortly, but at least did allow me to do some blood work. To his surprise, his white blood cell count was low, 3.8. His hemoglobin was normal. His hematocrit was low. His hematocrit actually was 42. And then his platelets, they were quite low. They were at 79,000. So we did some other testing as well to reassure ourselves that we weren't missing anything. His hepatitis B and C, they were negative. HIV was negative. This is a patient that actually doesn't drink any tonic water either. So upon evaluation of all different vitamin B12, iron, vitamin folate, none of those were deficient. Kidney function completely preserved. Definitely AST, ALT elevated as expected on someone who has chronic consumption of alcohol. Right now we're waiting for results of imaging, but definitely it was a quite big evidence for this patient that alcohol is affecting him systemically, and definitely now he's showing a lot of willingness to change. So hopefully we can get to a treatment pathway that allows him to see improvement of his alcohol consumption. And we will see, depending on the staging on how his liver looks, where the potential for recovery of this patient. But that's why definitely having a good idea in our complete blood count and as well on our complete metabolic panel on abnormalities that we can see due to alcohol consumption when we have studied the patient really well, right, can be extremely helpful. Now, on those who do allow me to perform a specific testing for alcohol, I tend to use any of the three following tests. One of them is going to be the carbohydrate deficient transferrin. That one tends to be generated because alcohol is able to inhibit the glycosylation on transferrin, and pretty much it can give us the elevation of this marker specifically can tell us the consumption of alcohol of a patient for the past 2 to 3 weeks. There is no specific correlation in between the titer itself of the test and the alcohol consumed, but definitely elevations may be quite helpful to show a patient that definitely we're having excessive consumption of alcohol. Is really the sensitivity is not great. It's quite specific, but definitely sensitivity is an issue. And on patients with severe liver disease, it becomes completely inaccurate. So in my patients with cirrhosis, we don't use it frequently. Another marker that I use more frequently definitely is ethyl glucuronide and ethyl sulfate. These two metabolites will be found in urine specifically. And as well, we can find it in blood and hair. The easiest sample, to be honest, tends to be urine. It's going to allow for detection of alcohol usage in the past 72 hours. So if we have someone who's unable to communicate with us that whether they have or have not had any alcohol consumption in the past 3 days, acetylchoronate and ethyl sulfate are extremely, extremely helpful. And as we can see, the sensitivity and specificity is great, pretty much 89% of sensitivity and 99% of specificity. So they're great tools to be able to assess our patients. And one that definitely is gaining more and more capacity to be utilized, especially with the patients that I tend to manage in the inpatient setting, and even outpatient, is phosphatidylethanol. So this is a direct metabolite that only alcohol can produce when attaches to some specific proteins on the surface of the red blood cells. So it's quite specific. The good thing is that it's not going to be influenced by age, BMI, gender, whether a kidney disease is present or not. But more important, if someone has liver disease, also it will not be influenced at all, as we're not relying on proteins on proteins produced by the liver to be able to detect it. We're going to be relying on how alcohol, specifically ethanol, interacts with the surface of the red blood cell. Now, some people may ask, it's not common, right? But there are some individuals that might engage on the usage of isopropylic alcohol. It's not frequently to be seen here in the US, okay, just in a few areas of the country, okay, but in some other countries, it's common that isopropylic alcohol can be utilized as means to obtain inebriation with alcohol. The cool thing about phosphatyl ethanol is that it's specific to the type of alcohol. So if someone drinks isopropylic alcohol, we're going to have phosphatyl isopropanol as the metabolite produced. So it's a totally different test. Same thing if someone was to consume methanol, even as accident. So that even if someone combines a different types of alcohol or a different type of alcohol is being suspected, or let's say that it's one of those things in which we think, well, maybe during puncturing the patient, we put too much alcohol on their skin. And if we use isopropylic alcohol, right, definitely the path will not change at all. So it is going to be influenced only and only by the usage of ethanol. It has the capacity to tell us the alcohol consumption for the past 4 weeks. So definitely it's lengthier than CDT in this case, definitely way better than ETG and ETS. And as we can see, the sensitivity is pretty high, is 91 to 100%, and the specificity as well from 77 to 96% as well. So everything will depend on that window of time in which we're able to obtain the sample from the patient. There are a few described false positive with phosphatyl ethanol. The real false positives, there is lack of understanding how that might have occurred. But also we have what we call artificially positive phosphatyl ethanol. When can that occur? And what do we mean by artificially positive? What we mean by artificially positive, it means that the test is positive, is definitely a test that con of a person that has some alcohol content or at least alcohol consumption for the past 4 weeks, but in a different body. Example, it has happened occasionally on some of the patients I evaluate that when striving to see if they're going to qualify to receive a liver, that they tell me, look, Dr. Meza, I haven't had any alcohol for the past 4 months. And which to us, definitely the date of sobriety is key to identify the possibility to have him be on the transplant list. And let's say I do a phosphatyl ethanol and that PET test comes back positive. How long did I say that the PET test is going to detect alcohol consumption? Usually 4 weeks. That's what we expect to see. But this patient is telling me that hasn't had any alcohol for the past 4 months. How can that happen? So in that case, what we need to look, and especially what I look for, is any history of transfusion in the past 4 weeks that has occurred to this patient. Because this patient's PEth, it is positive, especially if mild. And what I mean by mildly positive, I refer to values that will be lower than 100 on the scale of PEth, okay? And the situation is that if someone receive a blood transfusion, and customarily we do not test for alcohol consumption or PEth to individuals who donate blood, that PEth is positive, but it's from the blood that was actually given to the patient during transfusion. So that's how an artificially positive test can occur. It is a positive test. It is a sample obtained from this patient, but in reality, that sample contained blood that was transfused to this patient that made the test to become positive. So we've seen it in about 7 cases of the ones that we have had the opportunity to transplant, and definitely we have really clear explanation on how that happened, looking at the chronology on when transfusions had occurred. But PET extremely useful for us at this point in time, especially in the post-transplant setting when we want to have early detection of reengaging or return to use, as it's called. Now, the treatment for alcohol use disorder definitely is interesting because similar to the treatment of diabetes, right? It's not just necessarily to concentrate on, okay, what medication am I going to give to this patient, right? We have to look at multiple aspects of things, right? Definitely we're going to see that alcohol will have some uh, aspects in which is going to be intertwined with negative emotionality, for example, people who are depressed. Some of us, we might have anxiety. With some of us, we might have irritability, in which we find alcohol to be the one that has been treating these conditions for us in the past. Similar situation to what we see in diabetes and obesity, right? Those emotional eaters that we may see, right? So it's not just the medication what we need to think. Then, as well, we see incentives. Uh, just 3 days ago, I had this poor patient. Sadly, right now, she is admitted in one of our hospitals, okay? And she told me, look, Dr. Mesa, honestly, in my case, my goal was not to drink anymore. And I stopped drinking for a whole year. And once my anniversary came, I thought, you know what? I need to celebrate because I've been sober for a whole year. Sadly, for this specific encounter, the only way in which she knew how to celebrate it was by having a party and having some cocktails, and she did. So after 1 year of sobriety, she definitely described that she was feeling better, her depression was better, and anxiety as well. She re-engaged in alcohol intake and was unable to stop to the point that now she's actually admitted at one of our hospitals in a really serious condition. So uh, definitely the way in which we might reward ourselves, right? If we don't have any other means in which we tend to find enjoyment of big achievements in life may affect us as well. Needless to say, the social environment is big, right? Whether it's social pressure, network support, commercials, right? Games. You see a game, there is no game in which a specific beer may not be commercialized. So you're always having those visual cues around you. So in our case, when it comes to the treatment of alcohol use disorders, we have to do definitely multiple approaches. We have to go with the psychosocial approach, in which is going to imply the use of therapy and as well mutual help groups to allow these our patients to engage into a sober community, and in that way find that there are ways in which you can enjoy activities in life without necessarily partaking on alcohol usage. I don't know if you have noticed that even on concerts, okay, there will be areas that will be flagged yellow. And those yellow flags, for the most part, when you see them in a concert, implies that a sober group is in that area. So it's just a marker for people to know that you can enjoy concerts, you can go to festivals, and still be sober. Besides the psychosocial approaches, we have pharmacotherapy as well. Definitely, we have really good medications that can help with the use of with decreasing alcohol usage. We spoke about these ones in the last conference. We spoke about naltrexone, acamprosate, and even disulfiram. And needless to say, multidisciplinary care, in which we're going to have not just necessarily the approach with medications, but also we're going to have therapy involved in other different, whether it's empiric or evidence-based approaches that can help patients to refrain from alcohol usage. Why is all this important? Why is our goal to whether it's decrease or maybe even stop using use of alcohol on some of our patients? And it's because of this iceberg that we see right here, okay? I bet whether you're a cardiologist, you're an endocrinologist, you may have some type of surgical degree. Okay, I bet that all of you have seen at some point someone who has fatty liver. It's a given. It comes to the territory. It's really, really common to see this diagnosis. Now, let's not forget, fatty liver is going to be either a sonographic or, better said, imaging diagnosis and a pathological diagnosis as well. At the end of the day, when it comes to the pathophysiology itself, it's our duty as physicians to find out what's causing that inflammation or fatty infiltration of the liver. And as I mentioned before, we don't have to go too far, right? The two main causes of cirrhosis at this moment in time in the United States of America in 2025 will be alcohol and hepatitis C viruses. So we know that from the get-go. So alcohol will start as well as fatty liver. This fatty liver is going to be pretty much a process of inflammation of the liver. If inflammation is not resolved, definitely is going to lead to fibrosis and posterior development of cirrhosis. If we recall adequately our Harrison's principles of internal medicine, right? It used to be mentioned that it takes anything from 10 to 15 years of high level of consumption of alcohol for someone to develop cirrhosis. For the most part, that has been truth. But there are factors that nowadays we know they can actually accelerate this process. Let me give you an example. Now, in the days in which semaglutide, tirzepatide, and all these medications are so famous, we're having or we're seeing a decrease on patients undergoing gastric bypassing. Now, gastric bypass is quite of a really good procedure for the intent for which is utilized. Being that said, when it comes to individuals who do consume alcohol regularly, and if not advised well, and they do not acknowledge or know the potential effects that gastric bypass has on the absorption of alcohol, we're going to see that definitely the potential for this process that we see here, from fatty liver all the way to cirrhosis, will be accelerated. It won't take 10 to 15 years. It's going to be shorter. And why is that? Because when we bypass the stomach actually has the capacity to reduce some of that alcohol to an extent, decreasing its capacity to be absorbed. When we bypass the stomach and everything connects directly to the small intestine, the absorption of alcohol becomes easier, and definitely we have more bioavailability of alcohol that is going to affect the liver in quicker fashion. So definitely some of the factors that increase risk to the development of cirrhosis we can see uh, on this slide, right? We're going to, one of them is going to be the consumption of alcohol above the thresholds that the CDC of Atlanta has established to be somewhat safe. Now, if we recall the WHO comments, there is no amount of alcohol that is deemed to be safe. But based on current guidelines by the CDC, we know that is 1 drink a day for women or more than 2 drinks a day for men, definitely the risk increases. Needless to say, daily drinking while fasting increases the absorption of alcohol as well. Binge drinking, all those factors will definitely affect or produce cirrhosis in more accelerated fashion. Smoking of cigarettes, because as we know, definitely cigarettes are going to be carcinogenic on themselves. Needless to say, with the mounting effect that alcohol can have, it's a double punch to the liver. Female gender is another definitely factor that we know is more associated with early development of cirrhosis, and it's something that we see more and more commonly. Still, the majority, if we go back to our first slide, we're going to see that the majority of consumption still occurs on the male population. The majority of liver alcohol associated liver disease is still on the male population, but the number in women continues to increase as the consumption in women increases as well. Some genetic factors, we have some specific genes that are associated with the earlier development of cirrhosis. Increased BMI, because same thing as it happens with smoking of cigarettes, we, by increased BMI, likely we have metabolic syndrome, and you're going to see more and more of these diagnoses in which you have a combination of the two of them. We have a combination of cirrhosis secondary to alcohol use disorder or excessive alcohol consumption. And then you have these patients in which is alcohol due to excessive consumption of alcohol, but also they have metabolic associated liver disease. So in the same token as it happens with cigarettes, definitely the excessive consumption of fats and or sugars definitely is going to affect how quickly cirrhosis can develop. And needless to say, some other chronic conditions such as chronic viral hepatitis, hemochromatosis, NAFLD, NASH, autoimmune conditions, PVC. So we do have multiple ways in which the liver can receive insult. Are there any factors to decrease risk? Well, one, any of the modifiable factors that increase risk, if removed, the risk of having any complications with our liver decreases. Interestingly, though, and this is just because I'm a highly caffeinated individual, I find this really interesting, is that coffee consumption actually protects against cirrhosis in many causes. Now, it doesn't mean that if I start to drink a lot of coffee, I'm going to be able to overcome or block the effects of alcohol on the liver, okay? But definitely, it has been seen that coffee is hepatoprotective in this case. Some equivocal factors, the type of alcohol consumed. Some people think, okay, if I drink tequila, it's going to be worse than if I was to drink beer. That doesn't quite correlate, to be honest. I see patients with cirrhosis with any type of alcohol that they have consumed, whether this is wine, beer, IPA, or blonde, is going to happen. And as well, moderate alcohol use in patients with high BMI. There is no specific way to say that if we stay at a lower level of alcohol consumption, if I have a high BMI, potentially NAFLD, if that will suffice for me to decrease my risk to develop fibrosis and then posteriorly cirrhosis. Okay. Now, definitely, there are so many drinking patterns that the National Institute of Alcohol Abuse and Alcoholism has described to be on the look for. For the most part, we know that dangerous intake of alcohol is going to be any pattern of drinking alcohol that brings blood alcohol level concentration to 0.08%, okay, or higher than that. Now, we're not measuring that in every single individual. So, for example, we have some other ways to approach this. So, the NIIA has mentioned that high intensity drinking will be the consumption of 2 or more times the sex specific threshold for binge drinking. So, high intensity drinking, for example, will be 10 or more standard drinks for males and 8 or more for females. Definitely high intensity drinking, the more frequently it happens, more likely to cause cirrhosis at some point. Heavy drinking is going to be for men that consume 5 or more drinks in any day or 15 or more per week. And as well, we're going to have for women 4 or more in any day or 8 or more per week as well. So definitely we have these definitions that we tend to utilize. You can find all these ones online at any given point in time. Now, we have 3 different manifestations that alcohol can lead to when it does affect our liver. So it's going to be from something as inflammation, as we can see, alcohol associated steatosis. For the most part, it's going to be usually asymptomatic. With a good physical exam, we might have findings of an enlarged liver, but we may not find any jaundice. We may not find any stigmata of liver disease. And seldomly, we're going to find AST or AST, ALT, or GGT elevation. Okay, everything depends on how acutely that inflammation has occurred, but it can also go without elevation of any of these 3. Okay, so everything will depend on the periodicity of alcohol intake. It might go undetected and progress, as we can see here, from steatosis, occasionally alcohol really associated hepatitis. Some occasions, even this portion might be skipped depending on the if the intake of alcohol is not severe enough to cause massive acute inflammation, it can just progress to alcohol-related fibrosis, and then posteriorly to cirrhosis in this case. Interestingly, as I mentioned before, I encounter in my pre-transplant evaluation multiple patients that tell me, yeah, someone told me I had fatty liver 8 years ago, and for the most part, Dr. Meza, I've been healthy. I go to my doctor. They never tell me that anything else is going on. I I I actually restarted to drink because they told me my liver was better after 1 year of just not drinking. So my liver got better, so I started to drink, and after that, I never had any other abnormality in my test. And now you're telling me that I have cirrhosis and I need a new liver. It can be that sudden on some occasions. It's not the most common picture, but it can happen. So definitely we can diagnose cirrhosis at the time of decompensation. We won't be able to know if it's alcohol, the cause of cirrhosis, okay, unless we definitely perform a liver biopsy, which is not recommendable on someone who might be thrombocytopenic and with, at this point, problems in coagulation as well. But a nice history obtained from a patient is going to give us the idea that possibly alcohol was the reason for which he uh, he or she may not be may be having long-term effects of alcohol in their liver. And then as well, throughout all this spectrum, from steatosis to fibrosis to cirrhosis, at any given moment in time, depending on our alcohol consumption, we can have also alcohol-associated hepatitis. In this case, it's going to be definitely acute inflammation of the liver, which can go from acute liver failure to even potential fulminant liver failure and potential death. Okay. So how do we know when someone is having some alcohol-associated hepatitis? So usually we're going to have three different groups, right? The definitive uh, alcohol-associated hepatitis. For that one, we need to definitely have a biopsy, okay? When we have probable alcohol-associated hepatitis, it's going to be based on history of excessive alcohol consumption. Definitely elevation of bilirubin, elevation of AST, ALT, more than 1.5, the upper limit of normal, usually less than 400 in the majority of cases, with an AST, ALT ratio, if we recall the really well, described to be 1.5 to 2 to 1, the ratio of AST to ALT, and definitely we don't have any other potential cause that might be leading to the inflammation of the liver in such a sudden fashion. And then we have possible cases of alcohol-related hepatitis, which is some of them that do not necessarily meet criteria, in which alcohol may not be the solely explanation for the inflammation. And we see some of those in our patients, especially in those that have comorbid elevated BMI, in which metabolic associated liver disease might be another way to that the liver can be affected. Then we have different ways to score and prognosticate the possibility of mortality of a patient who's enduring alcohol-related hepatitis. One of them definitely is going to be Madrid's score, in which definitely when more than 32, right, we know that the risk of short-term mortality is pretty elevated, pretty much 30 to 50% in the next 28 days. Is going to help us to determine if a patient may benefit or not from treatment with steroids. MELD is going to also indicate the possibility of alcohol-associated hepatitis. A MELD of 21 tends to indicate us that. And it might lead us as well to think that the steroids might be a good option. Another thing for which MELD can be utilized, especially MELD-PELD, especially the version 3.0, is going to help us to define if the patient may be considered for liver transplantation at this point with the recent diagnosis of alcohol-related hepatitis. And definitely little score as well, which is going to incorporate changes on bilirubin at 7 days after we start corticosteroid usage in patients with alcohol-related hepatitis to see if there is any appropriate response to treatment. So How do we treat alcohol-associated hepatitis? As I mentioned before, definitely the evidence-based treatment is going to be steroids, depending on scoring itself, but also absence of contraindications. If someone has a concurrent infection as well, steroids might not be indicated. Pentoxifilin hasn't been seen to have any uh, major therapeutic benefit at this point in time. And then as well, we need to start thinking, okay, so if we treat this episode of alcohol-associated hepatitis and a transplant is not needed, are there any other uh, factors that can be used? Yeah, the first thing is going to be abstinence. So abstinence of alcohol usage. So definitely engage patients to either see an addictionologist or start medications for alcohol use disorder at that moment in time. Nutritional therapy is key as well. Definitely have a good nutritional status will allow for faster recovery. As I mentioned before, corticosteroids is key. N-acetylcysteine, and I know that we always remember N-acetylcysteine, especially when the condition that we're treating is poisoning due to paracetamol or acetaminophen. But it has been seen that prednisone plus N-acetylcysteine can be helpful as well for when we're facing alcohol-associated hepatitis and other type of acute hepatitis, except viral, on our patients. So definitely all these are important factors, plus definitely any other symptomatic management, right? Nutritional therapy, we can include fluids, right? Make sure that our patient is hydrated and have a nice urine output as well. Here we have, as I mentioned before, some of the contraindications to steroid treatment. Definitely someone who has an active infection, right? Like right now we have someone in ICU, Ronald Reagan, who actually has fungemia. We're unable to provide steroids at that moment in time, at this moment in time. As well, someone who has uh, gastrointestinal bleeding or who has had who is bleeding right now. Now, once the control of the bleeding has occurred, definitely steroids can be given, so it's not an absolute contraindication. Okay, patients who have acute kidney injury. Okay, for the most part, most patients in which alcohol-associated hepatitis trials were performed by using steroids, patients with acute kidney injury were excluded. So we do not know the safety of doing so. But once definitely there is recovery of the EGFR, definitely corticosteroids can be reconsidered. And definitely anyone with active hepatitis B, as this is going to cause a flare on hepatitis B as well. Mhm. Right here is just to define patients that definitely may have some benefit or not. As I mentioned before, N-acetylcysteine has a potential benefit to improve the outcomes of alcohol-associated hepatitis. And as I mentioned before, we used to be taught that pentoxifilin can be a potential agent that we can use when corticosteroids cannot be utilized, but definitely hasn't been seen to have any major benefit as of this moment in time. And then we have a couple more right there that I'm not going to go in depth right now. Now, liver transplantation for alcohol liver disease. And as I mentioned before, at least until 2019, 2020, hepatitis C virus was the leading cause of liver transplantation, the leading cause of cirrhosis that require liver transplant. Nowadays, it's alcohol at this moment. So definitely something that we need to keep paying attention to. So some indicators for referral, there will be new onset of decompensation, SBP. Definitely if someone has HCC diagnosis, likely due to alcohol, it's a good idea to be referred to a center that performs a liver transplant. And definitely patients who, despite abstinence, uh, they just haven't improved, right? They continue to have ascites, needing paracentesis maybe every week, maybe twice a week, right? So definitely those patients is a good idea to consider to be referred to a center that might be able to perform a liver transplant for consideration of transplantation at that moment in time. Something that is an antique belief is the belief that someone has to be abstinent for 6 months at least in order to be considered for liver transplantation. What it used to be known as the 6-month rule. In reality, it wasn't really, it was actually an arbitrary rule established to be able to qualify for insurance to cover liver transplant back in the days. That caveat was removed quite a while ago. So depending on the transplant center that your patient may be evaluated, they may or may not take these specific into account. So UCLA, for example, I can attest that there are patients that will not meet sobriety criteria by 6 months, and yet they're placed on the list and even they receive a transplant depending on some other factors that are evaluated for the patient, especially if they have multiple protective factors, they will be considered as well. I can't speak for every center, not even for in California or not even in Los Angeles, because each center has their own rules and regulations. So definitely it's pretty specific to each center how they approach abstinence and protective factors for patients themselves. Now, the good thing is when someone actually has liver transplantation due to alcohol liver disease, 85% has a really of survival rate in the next 5 years. So it's a pretty good survival rate, what we see. Uh, Sadly, we do have that 20 to 25% of individuals they will re-engage or they're going to reinitiate the use of alcohol at least within the next 5 years. So our goal right now, specifically where I perform my duties, is to detect in early fashion when someone re-engages on use of alcohol, so we can strive to treat early um, that return to use with that patient. And amongst the people who relapse, about a third of them will develop cirrhosis after 5 years following liver transplantation. So out of these 20%, one third of them will develop cirrhosis, requiring potentially a second transplant that, depending on the center, may or may not occur, depending on the rules and regulations that they may have. Now, what can we do in our case? Well, definitely the good thing, as I mentioned last year in our conference, we have really, really good medications that can help to individuals to refrain from alcohol usage, whether these ones are FDA approved or off-label medications. FDA approved, we're going to speak of medications such as disulfiram, naltrexone, or acamprosate. And off-label, we're going to have medications such as baclofen. Topiramate is becoming more and more popular because it does decreases anxiety on a lot of patients. So definitely it's a really good mood stabilizer for them. And as well, gabapentin, and there is a small evidence of varenicline, but still not completely certain on how much varenicline can help with refraining from alcohol usage. So some of the important things that I want to uh, pretty much have all of us to remember after this nice conversation that we had. One, screening is key. Okay, having that open conversation with our patients, not just to think that fatty liver means we're eating too many greasy foods, but definitely can be anything that causes inflammation of our liver, including alcohol. Two, we do not like to tell patients what to do. I do believe a lot on the principle of patients having the capacity to make their own medical decisions. So the principle of autonomy is important to me. But let's not forget the word doctor means teacher as well, right? So there are some patients in which I'm going to teach and show why abstinence might be the best approach to take. It might be necessary. The patient can take it for what it be and do it or not do it. It's their choice, but at least my duty is to teach and show why it's important potentially to become abstinent from use of alcohol. Treatment for alcohol-associated hepatitis. As of this moment, the best evidence definitely with prednisone, maybe some N-acetylcysteine as well, and that there is option always for transplantation of the liver. Okay, the important thing is to detect that patient that is willingness to have a meaningful change of their life. For the most part, most centers, as I mentioned before, I can't speak for everyone, but definitely most centers will require that patient to commit to full abstinence post transplant, which is going to be one of the keys, definitely. But anyone can be considered, as we don't have the 6-month rule anymore. So where is the research going at this moment? Well, the first thing is to try to assess prevalence a little bit more, okay? Even when it comes to the relapse rate that you saw right there, 20 to 25% of people actually mentioned that they return to use within 5 years post-transplant. But that's only and only if the patient volunteers that information or if a decompensation occur. The number might be higher than that. Now that we have tools such as phosphatidylethanol, ethanol, in our case at UCLA, we definitely test every single patient for a whole year, before every single visit to see when the return to usage may occur. And after 1 year, we do it randomly as well, just to make sure that we see who has re-engaged on use of alcohol so we can treat early. Definitely alcohol use disorder treatment efficacy. We have more medications maybe on the pipeline to be able to help patients with alcohol use disorder. Biomarker development right now, we have one that is quite specific, extremely specific, quite sensitive as well, so it's really helpful for us. Possible new therapeutic targets, and needless to say, some more research around transplantation on how to help these patients to recover well. These are the references that I have for you, and thank you very much for your time today. We're committed to definitely provide the best care possible to our patients with alcohol use disorder and liver disease. Thank you.